Dr. Roger McIntyre, who is currently a professor of psychiatry and pharmacology at the University of Toronto in Canada and head of the Mood Disorders Psychopharmacology Unit at the University Health Network, also in Toronto, Canada. Dr. McIntyre is also the executive director of the Brain and Cognition Discovery Foundation in Toronto, Canada. Dr. McIntyre is also the director of the Depression and Bipolar Support Alliance from Chicago, Illinois, USA, and Dr. McIntyre is the founder of the Canadian Rapid Treatment Center of Excellence. Dr. McIntyre has also been a contributor to the Florida psychopharmacology guidelines, and he has been the lead author on our guidelines on major depressive disorder and bipolar disorder. So we are very pleased to have such an expert to talk with us today. And we want to talk today about the new ketamine guidelines, the ketamine guidelines that have recently come on and have been released. And Dr. McIntyre is one major contributor to the production of the guidelines. So with that being said, Dr. McIntyre, I would very much like you to briefly give us, what's the exciting part about, the ketamine and esketamine guideline for the treatment of refractory depression? So could you please just briefly tell us, as opposed to for the patient who has failed several treatments of antidepressants, ketamine is good news. So tell us why.
Yeah, absolutely. And Marie, wonderful to be with you and joining you for this discussion. I would say that for me, the positive, the excitement, and I think that the justifiable excitement about ketamine and esketamine for people who will live their life with depression is that it gives them hope. And what I have learned as a practitioner when I meet people with depression is, of course, we want to improve symptoms. But what I have noticed, what is even more fundamental, is that people, when I meet them, have often lost hope. They feel there's no hope that they can return back to the life that they want for themselves. And what we want to provide for people is not false hope, but actually true hope. And I do not believe that esketamine or ketamine is the cure for depression. I do not think it's the panacea for all people with depression. But what it has done in a substantial percentage of people in our clinic and in our experience, and certainly the literature reads this out, is that it has provided a robust improvement in areas that matter most to people. And we've seen people not only exhibit symptomatic improvement. Marie, you and I know this well. Symptoms matter, but quality of life, function, patient-reported outcomes mean more. And we are seeing benefits in those areas within 1 to 2 weeks of administration. So I think it's exciting in the sense that it really helps people who suffer, especially people who've tried familiar antidepressant strategies to no success. And this gives them a true hope avenue. Now, that being said, as I said, it's not going to be the cure for everyone. It's not going to work for everybody, but it works for a significant number. One final comment about this is me speaking as the scientist, as the academic, is this is the first time, Marie, in 70 years that we have an antidepressant that is not targeting the classic monoamine system, that's targeting glutamate. And that's academically interesting. That might not be as interesting at the clinical encounter, but academically it's interesting because I think we have had some innovation stagnation in our pharmaceuticals for depression. And this speaks to a very new direction that we're going. And this, along with other directions, are, again, giving hope to the field.
So what's the ideal candidate for ketamine?
I would say that, there's two answers to that. For a person to be eligible for ketamine, and this is really important that practitioners are aware of what is the appropriate patient selection. We always say treatment-resistant depression. And I often finish that by saying that treatment-resistant depression is more of an adjective than it is a noun. So treatment-resistant depression is a very broad group. In the DSM-5 language, that includes major depressive disorder and the bipolar 1 or bipolar 2 disorder. And people have had often chronic, often severe, but what's consistent is they've had treatment resistance to the conventional approaches, which we define as an insufficient or suboptimal response to at least two conventional approaches. So if we define treatment-resistant depression in major depression, bipolar depression, is insufficient outcome to two conventional approaches, I know clinicians listening in are going to say, that makes up a lot of people that I see. And you're right, it makes up like 2/3 of the people that we see. It's a lot. Within that sort of broad, eligibility, treatment-resistant depression, what I found, Marie, is that people who come to the clinic with treatment-resistant depression who say that they have profound anhedonia, they have problems with anticipating pleasure, which is usually manifested as fatigue, lethargy, apathy, and or they say, I have no joie de vivre. I want to say joie de vivre because I know, Marie, you know what that means, the French. But no joie de vivre, there's no life. And this is what people want. And I have found disturbances in both anticipation and consummatory anhedonia really responsive to ketamine. The second area that I have also found that really helps patients is what I call AIA, anxiety, irritability, and agitation. Now, again, I'm getting into some of the weeds here, some of the granularity, but we see a lot of people who are anxious, irritable, and agitated. Some of these people have mixed features. But the point is, these are symptoms which are often persistent, often don't respond to conventional monoamines, and it is obviously very unpleasant for those who are affected. So that's two areas I find extraordinarily responsive. One final point about that, we've just reported on this, which is interesting, Marie, patients reporting improved cognitive function. That comes as a bit of a surprise to people because people often think about ketamine as special K, abusing ketamine on the street, which we know interferes with cognition, but we're talking about sub-anesthetic ketamine in the treatment arena. And the data now give us reasons to believe that there are domains of cognitive performance that are critical to health outcomes like day-to-day function that are improving with ketamine. And I would conjecture, I don't know this, Marie, but there's some preliminary evidence now indicating that ketamine and esketamine reduce suicidality, and that's a different phenotype altogether. It overlaps with depression. And I've often wondered academically and clinically, is the reduction in suicidality in part because of improvement in cognitive domains like impulsivity? So taken together, anhedonia, AIA, anxiety, irritability, agitation, and cognition really benefit with this treatment.
So could you eventually see that the patient who present with initially with those severe symptoms, would ketamine then could be a first-line treatment as opposed to trying everything else and then finally ending up with one ketamine, or try all the others first and then, or could it be a first-line treatment?
I do. I think it could be a first-line treatment, and I think there's some stepping stones to that. The first is we need to obviously do the studies in non-treatment resistant depression, and as always, we need to document safety and efficacy. I do believe that philosophically, psychiatry has always been peculiar to me, the profession I love so much. In other areas of medicine, they don't wait until stage 4 illness before they get serious. But in psychiatry, we seem to wait until the illness is in stage 4, code red, before we get serious. And what I mean by that is I think there's an urgency that we need to bring to the clinical encounter that I just don't think is there. Depression and bipolar, they're malignant illnesses. Nobody wants these illnesses. They really impair their lives, their livelihood, and reduce their lifespan. So I think if I was looking at this, if I had a choice and I had never been exposed to medication before, and I had a treatment that could work within a few days, without the burden of sexual dysfunction, weight gain, and other sort of quality of life interfering side effects, I would absolutely want that. To me, the way I'm thinking about this more and more, Marie, is that it's a bit like migraine. If you have a migraine, we give you a treatment to end your migraine immediately within the day. And then we give you something else, maybe to keep the migraine from coming back prophylactically. And admittedly, the limitation of ketamine and esketamine is its relatively brief duration. That is the duration where people stay well. The median duration is only about maybe 2 to 4 weeks, around 20, 23 days. So people require boosters. They require some type of intervention to prolong the efficacy. And outside of giving repeat esketamine or repeat IV ketamine, we don't really have an evidence-based strategy. And I think that's a research question. It's obviously clinically relevant, but I could imagine the future, we give people who've never had medication before, ketamine or esketamine, and maybe they might get internet-based guided CBT as a way of prolonging the efficacy. Maybe it could be some other psychosocial intervention. Maybe it could be an easier to administer medication to be determined. I don't know. I think we already kind of have this avenue paved out for us, because just last year, the FDA approved esketamine for adults with depression and suicidality. And so those are not treatment-resistant patients. So not just in theory, but if you interpret the indication that the FDA has given to esketamine, it does suggest, or at least I would interpret it, that someone who's presenting for the first time with depression and suicidality would be a candidate for esketamine. So we're already seeing that avenue paved out. But the question you asked, I think, is a zinger, because that's the question as a field we need to address. And there's newer rapid onset or rapid acting antidepressants that are expected to be approved by the FDA over the next 1 to 2 years. This is a conversation we're going to have.
Absolutely, absolutely. I totally agree with you. Now, the other issues that I'd like to bring about this, about ketamine and esketamine, clearly there are issues of implementations. Yeah. And as we all know, that there is a crucial shortage of psychiatrists, and a lot of depression or severe depression is being treated in the primary care sector. Now, clearly primary care physicians have come a long way, and they're getting more knowledge about pharmacotherapy of various medication. However, they're not the experts, and they'll be the first one to admit it. Yeah. So how, given the fact that still ketamine and esketamine do require monitoring,
yes,
how do you start the conversation with the patient who may obviously be in a state of anxiety or under depression? How do you start that conversation, and do you go to express to this patient that you will need to go to, perhaps I'm not the one who's going to administer, because it's an infusion, correct?
Yes.
So how does that start? That's to me a crucial issue in implementing this treatment.
It truly is. And I know, Marie, that because I know we've had these discussions before, you and I have talked about the importance of implementation, for example, with guidelines. And we know that more than 3/4 of recommendations in medicine are not implemented. And if they are, they're not implemented in a timely fashion. So I think that when we have an innovation in medicine, that innovation loses a lot of its caffeine punch, if you will, if we don't have an implementation plan. And we've had a congenital problem in North America, and that congenital problem is we've had a congenital problem with insufficient access to mental health care services, right. And it's been a problem. What's interesting about ketamine and esketamine is that across America during the last, we'll say 5 years, a bit longer, but say 5 years, there's been a large number of clinics that have appeared across different states, more populated states, less populated states. And I've lost count, but last time I checked, it was more than 175 to 200 clinics across the country that were giving ketamine or S-ketamine for people with depression. I think that one of the reasons we prepared the international guidelines, which we published in the American Journal of Psychiatry on ketamine, S-ketamine, is first of all to provide practice parameters, best practices on how to patient select, how to really use the drug carefully and appropriately, and what's the appropriate setting. And then that latter part gets to your question. I do think it's going to be a rethink. And I, if you would have asked me a year and a half, 2 years ago, I probably would have been a bit more, maybe a bit more frustrated with the lack of progress in digital, in telehealth, telemedicine. COVID-19 has been a terrible situation, but one positive is I think it's really adopted people into the tele-world, into the virtual world.
Very
true.
Yeah.
And what my hope is, and I hope this comes true, is that we will have, as a consequence of COVID, a more accessible, more available, more equity in our mental health care services. And then within that, it would seem to me, for example, that dashboards can be created where clinicians at the point of care, rather than having to struggle to find someone to give ketamine, S-ketamine, we're going to be more networked within dashboards, if you will. And you could have internet-based CBT, guided or unguided. You click this button you click to see your primary care, to make sure your diabetes, your obesity, your heart disease is evaluated. This click is, maybe you're a candidate for a rapid acting treatment like ketamine, S-ketamine, and then what's the referral, what's the route of referral, so the patient journey is seamless. Again, 2 years ago, I would have thought this was a bit more theoretical and more wishful. But I think what's happening with COVID, we're seeing a lot of goodwill around this, and there's been already some models playing out. So I think that the technology can facilitate this, creating dashboards. Admittedly, though, Marie, what I've noticed is that this is a general statement, is that there hasn't been a lot of cohesion around America with respect to ketamine and S-ketamine clinics, in the sense that they tend to operate as solo clinics. They're often not networked into health systems. And also, many, if not most of these clinics are operated by people who are not mental health care providers.
That is a big issue. Yes.
Yeah, it's a huge issue. And I think that, we have anesthetists that work with us. Anesthetists often run these clinics across America. Anesthetists would be the first ones to say, we're not mental health care providers. And I think that it's really essential that any coherent clinic that's offering mental health care services has to have mental health care professionals within the organization. I think no one's going to argue that. And so I know from firsthand what I've seen that this is a limitation. So I hope that along with bringing a network through digital, we also can supplement the existing clinics with mental health care expertise. Clinicians across America don't want to send their patients to clinics that don't have mental health care expertise. I would not send my cardiac patient to a cardiac clinic that has no cardiac expertise. So it'd be no different for depression. So I think this is a key issue. And I think that if the funding models are in place, because look, that does matter, the reimbursement models are in place. If we sort out the medical legal aspects across state lines, and I think we've done a lot of work with that during the COVID, I do think that with the technology, there is the opportunity for having a medical home that's much more integrated, the patient journey is more coherent, more longitudinal, multidisciplinary, and has a quality imperative. So I think it's possible, but obviously it's a lot there, and we know working in different healthcare systems, Marie, that there's a lot of stars that need to line up. But I think COVID could be an opportunity. I really believe that.
Most likely, and I agree with you. But Roger, is there a chance? To me, sometimes when I look at the ketamine implementation, I'm thinking about the clozapine uptake.
Yes.
Where patients have to be closely monitored. They have to go to a clinic, and we know that, there are transportation issues, there's all on the patient side, and that's a deterrent to implementation. How do we get around that? Is there, in the near future, maybe will the primary care physician or the psychiatrist, if you work into an integrated or semi-integrated model, collaborative care, could be administering the infusions of ketamine without the patient having to travel and make another trip to a clinic?
Yeah, that's such an excellent question. I think clozapine in treatment-resistant schizophrenia is an excellent example and a very, very much a cautionary tale because, as you were alluding to, most people who are candidates for clozapine with treatment-resistant schizophrenia don't get it, and often it's because, as you said, there's an attitudinal barrier because of the work involved with hematologic monitoring and so on. And so there's obviously going to be a lot of effort to implement ketamine with infusions. So I think it's an excellent metaphor, actually, and maybe an example to learn from. I think clearly what we have to be candid about is that clinicians are people, and people don't want more headache. They don't want to have more things put on their plate during a busy clinical day for no other reason than everyone's busy, everyone's time poor. And I think it'll have to come from a systems level. And I don't pretend to be an economist, but I know that our economic experts would say that from a health systems perspective, if we can integrate the care, then it's better for the individual, it's better for society at large, et cetera. And cynically, it's better for the bottom line financially if we can do this. Now, admittedly, not everyone's going to have the infrastructure and/or the scope of practice to give IV ketamine. But the way I sort of think about this, Marie, maybe optimistically, a lot of what I've noticed, and I would like to sort of emulate this around America, people go for infusions to treat their arthritis. If they have very bad arthritis, they'll go and they'll receive a monoclonal antibody that's infused, what I call the IBS and the ABS, those monoclonal drugs for, say, severe ankylosing spondylitis or even inflammatory bowel disease. And those obviously they're labor intensive, but I have found them to be much more streamlined and much more integrated into primary care. Psychiatry, as you know, going back from the start of time, has always been sort of siloed away from other medicine, but maybe we can lessons learned from how effective the infusion clinics have been around America with respect to treating people who have inflammatory bowel or have severe arthritis, who receive these state-of-the-art monoclonal drugs, which have to give through infusion. The other part is that I think that it needs to be made aware that S-ketamine, which is the nasal spray, can be given at point of care. To be perfectly candid, one of the aspects about implementation as a barrier has been the cost. It's quite costly.
Yes. That was my next question. Is it the insurance reimbursement is a problem as well? Is an issue. It's not like widely reimbursed. Let's put it this way.
Absolutely, and look, that's going to be an important point. And I guess if it's priced beyond the reach of the consumer, then it's just frankly, it's dead on arrival. It's not going to work. And that's been a major. I've heard from colleagues from Florida to California over to Hawaii, right across America. They say, Roger, this S-ketamine is too expensive for our clinics.
That's right.
And so I think we have to have a rethink there, and that's obviously a major problem. It's beyond our control. That's obviously the sponsor prices these things. I should mention that IV ketamine, at least on first glance, yes, of course, it's more labor intensive, but on first glance, it may seem like it's more expensive, but actually it's cheaper than intranasal ketamine. And we've shown this with our work. So that sometimes can be an opportunity for people who couldn't afford the S-ketamine. But I think, this has been another challenge we have in mental health, and that being, can we actually make this cost effective? Here's the thought. Here's a spontaneous thought, Marie. Just recently, it was announced by Walmart that they are interested in opening mental health centers in their stores across America. And many would know that Walmart I'm only picking them as an example because of their massive scale with up to 4,500 stores around America, often in places of medium and low income communities. And this is in fact the very communities that are underserviced in mental health and other areas, but mental health we're focusing on today. And I was really, a light bulb went off in my mind when I heard that Walmart was getting into this business. Now, cynically, you could say they're in it for their commercial reasons and all, and that's fine. But just to stay with the point, I think that if we can not just partner with pharmacies, you've been hearing about Walgreens, CVS, Rite Aid, you've been hearing about grocery stores like the Albertsons chain, now Walmart getting into mental health care with having clinics offering mental health services in the natural habitat in the community. I welcome that. I welcome the principle of that. And maybe because of the infrastructure of these well-oiled machines, I think there could be an opportunity to integrate some of these innovative ways of providing care. In other words, I think we have to agree that some of these organizations are outstanding at the way they implement, and maybe there's ways that we can team with these groups. Just like the vaccine rollout for COVID-19, we relied on some of these organizations, and I think there could be an opportunity. I think we have to be creative. I'm completely agnostic as to who we're partnering with, but we've got to get into the natural habitat so that it's easy for people to walk across the street, so to speak, and get this treatment. If they have to drive too far, it's not going to happen. So I wondered if there's an opportunity there.
Well, also, I remember I recently read within the last couple of days that CVS was also implementing mental health, as well in their pharmacies, and to have, camp psychologists or counseling made available at in their pharmacies, so which will also be a great. And I think you're right. It's very important to have. As we all know, mental health is one of a major burden, and increasingly so, it appears. So to have more opportunity for treatment, or someone who may not want to make an appointment with their physician or psychiatrist, again, stigma is still present. Maybe just walk into a pharmacy and get some privacy might probably be, certainly would be a good thing, that's for sure.
Absolutely.
I think a couple of years, 2-3 years ago, we ran a panel trying to figure out with physicians in Florida, trying to why the resistance to the implementation of clozapine. We know it's highly effective, just like ketamine is highly effective treatment, but it has some of the issues we discussed about monitoring and etc. And we found that the resistance was not so much on the patient side, but it was on the physician side.
Right.
Because they didn't want to get involved with the monitoring. It was complicated. They didn't know about it. So we implemented a hotline, the clozapine hotline, where a physician was contemplating using clozapine could call and speak with a psychiatrist, with expertise in administering clozapine, and perhaps to just give them a few tips on how to start. I was wondering perhaps if would be something similar with ketamine due to the sort of the innate resistance to have, like a lifeline, so to speak.
What a fantastic idea. And I'm not surprised that it really is it's the clinician who is often the rate limiting step. That's been my impression as well. But what I've noticed is, speaking to clinicians, not just across America, but around the world, is when it comes to ketamine and esketamine, all clinicians are interested in seeing their patients get better. They're human beings. They don't want more paperwork and more nonsense, and I don't either. We want, obviously, the path of least resistance. But I think that what I've noticed is that there's a lot of room for demystification. And because ketamine and esketamine is still relatively unknown. It's getting more known. I don't think it's well known. And as you know, Marie, ketamine has a romantic history dating back decades where it was used as a drug of abuse. There was a longstanding history where it was used in ways that were inappropriate. And so it has a certain stigma, I think, as well, that at least for some people, is a barrier for considering it as a treatment option. But I think taken together, I do think that your idea is excellent. I think it's about education.
Yes.
And people just need to have access to, like the hotline's a great idea, to not just have info, but to troubleshoot and to almost facilitate and ease the patient journey process. I think that would be wonderful. And I think that's what we really, really need. It's kind of interesting because I was thinking about the digital opportunity and digital, we're seeing more and more patient journey experts sometimes now can be even digital. And so it depends which generation people are in. I think the younger generation of clinicians is a bit more open to these things, I think, than the older generation. But anyhow, I think it's a great idea, actually. Because, it's funny because I've had this incredible privilege of meeting so many clinicians in so many different fora, whether it's in education or research meetings or so on. And many people, when I talk about ketamine, S-ketamine, still react with a bit of surprise. Oh, isn't that a horse tranquilizer? Isn't that a drug of abuse? Why are you guys using that in depression? Aren't you concerned about abuse, things like that? You know what I mean?
Mm-hmm. So no, I agree. There will be definitely an educational component for appropriateness of use, as well as who is the candidate, the ideal candidate. So that the education side is going to be rather important into the acceptance and to increase the comfort level of clinician to use ketamine. Well, it sounds like, you're well on your way, and it's certainly with the publication of the guidelines, it's going to give definitely a clinician, psychiatrist, and primary care physician some, guidance as to, implementation and usage. And from what I read in the literature, it seems like everyone seems to agree there is a place for ketamine, but the concern is that, the proliferation of these clinics needs to be reined in, seems to be more, because we don't want to have an issue when, it would be exposed in the paper that the abuses of these clinics. So
Yes.
I think it's a critical component of the acceptance to have appropriate and expert personnel staff these clinics, not just, someone who can inject you with provide the infusion. So again, I think it's clearly from what, the literature says, there's definitely a place for ketamine. And it's definitely provides a faster treatment than the usual routes of an antidepressant. So I hope it does well, and I hope it gets implemented, thoughtfully. That's the key,
Yeah, it's nicely put. I agree. Implemented thoughtfully is a really nice way and safely, and so patients are not harmed and that they're benefited. And it's interesting because I think that this is the start of a new direction in psychiatry, with anticipated approvals of other so-called rapid-acting treatments. So we're going to begin to rethink this, not just at the clinical point, but also at the systems level. How we do this safely, appropriately, ethically, and obviously in a way that's efficacious. So your point's very well taken.
Great, that's all right. So I wanted to say, sometimes psychiatry is very mysterious. It's hard to say, there are successes and there are failures, and it's hard to say, not everyone is the same, but it's just, it still has a little bit of a mysterious side to it. I mean, what works well, it's hard to explain the failures and the successes.
Absolutely.
And so I think it's we just have to be patient and realize that one size does not fit all, and clearly sometimes there is the art of treating that gets into the mix of treatment. So definitely thank you for explaining the ketamine, the new guidelines. And just on a closing, since you have your pulse on what is new out there, what's exciting and you coming in the next 2 to 3 years, what is exciting in the pipeline?
What's really exciting is that we have, in the area of pharmacology, I'll start with that, we have very new treatment interventions that are targeting innovative targets. For example, we anticipate later in the calendar year of 2021, again, these things are not yet for sure, but we anticipate that there will be a combination pill of bupropion dextromethorphan, which is a rapid-acting antidepressant that can be given orally. We know across America, brexanolone is an intravenous treatment for postpartum depression. We hope that there's a oral version of that agent, which is a GABAergic drug, looks really interesting. And then other targets would include, but not be limited to, so-called orexin antagonists, which many of our colleagues would know are drugs for sleep, but also are now being developed as antidepressants, as well as a variety of other approaches like anti-inflammatory approaches, to name one. Many would have heard about some of the excitement with so-called psychedelics like psilocybin and DMT, ayahuasca, ibogaine. I think we're going to have to wait and see where that goes. Marie, you know better than anybody yet about the role of implementation. There are many, many unanswered questions on the science around psilocybin, and many, many unanswered questions around implementation. So I think that psilocybin, ecstasy, some of these drugs that we're hearing about being repurposed, not just for depression, but for PTSD, drug and alcohol abuse, there's a tremendous amount of excitement. But I think we welcome the excitement, but we also need to be measured with respect to, let's not lose sight. We need to have good safety, efficacy, and implementation plan. And right now, that's still a work in progress, but it's exciting. On the non-pharmacologic front, we're seeing developments of more scalable neurostimulatory approaches. Maybe people could do these at home, neurostimulation, which is interesting. And what I find also very, very cool is the internet-based delivery of psychosocial interventions. We made reference to that. That's really gotten sophisticated.
Yes. Right.
And so I think that we really are entering a different time into psychiatry, and I think that I would call it a cul-de-sac. We've been stuck in a cul-de-sac, this innovation stagnation for a long time. Yeah. We really have a line of sight. So it's very exciting.
Excellent, excellent. Well, Roger, I cannot thank you enough, for speaking with us today and giving us, really a really good understanding of what the ketamine guidelines are, because it's been released recently, and I think, we certainly are very grateful for speaking with us. Thank you again, Roger. It's been wonderful.
Thanks.
I hope you can all travel and see each other pretty soon.
Oh, I would look forward to it. Thanks for having me, Marie. Always a pleasure.
Take care. Bye-bye.
Bye-bye.